The following podcast is part of a certified educational activity titled Breaking Therapeutic Barriers in Relapsed Refractory Multiple Myeloma, Team-Based Solutions for Integrating Novel Antibody Platforms and Improving Myeloma Care. Access the entire activity and complete the post-test at peerview.com/JBG860. Downloadable slides and practice aids are also available.
Welcome to Breaking Therapeutic Barriers in Relapsed Refractory Multiple Myeloma, team-based solutions for integrating novel antibody platforms and improving myeloma care. I'm Dr. Sagar Lonial from the Winship Cancer Institute of Emory University in Atlanta, Georgia, and I'm pleased to welcome my other panelists from Winship, my nurse practitioner colleague, Cherise Gleason, my pharmacy colleague, Dr. Catherine Maples, and my ophthalmology colleague, Dr. John Kim. So for today's agenda, we're going to talk first about an introduction to antibody therapy in myeloma, current guidelines, and why we need to do better in the context of relapsed and refractory myeloma. And then number two, tumor board discussions on managing patients in early relapse and those with more heavily pretreated disease and how effective sequential therapy with antibodies can lead to optimal clinical outcomes. So let's start off really talking about the story of antibody therapy in multiple myeloma. Before 2015, I used to joke about oncologic irony, the fact that a disease that makes too much monoclonal antibody didn't have a monoclonal antibody with which to treat it. And that changed in 2015 and 2016 with the approval of daratumumab and elotuzumab. And more recently, we've seen approvals for daratumumab in the sub-Q formulation, daratumumab in combinations for newly diagnosed multiple myeloma. We've also seen approvals for isatuximab in the relapsed and refractory setting. And more recently, we've seen approvals for belantamab mafodotin in the triple class refractory patient population. And each of these certainly represent important steps forward for us. And part of what we are challenged with now in 2021 is thinking about how to integrate each of these new treatment approaches in a way that is logical, that is coherent, and allows us to take full advantage of each of these drugs so that patients can get the best short-term and long-term outcome overall. Now let's start off with anti-CD38 antibodies. And what you'll see is that both daratumumab and isatuximab bind to CD38. And CD38 is present on the surface of plasma cells, probably in higher density than it is on other cells. And both of these agents appear to induce on-tumor effects through CDC, ADCC, ADCP, and direct cell apoptosis. Interestingly enough, daratumumab also appears to have an effect on immunosuppressive regulatory T cells, as well as myeloid dendritic cells, whereas isatuximab also seems to have activity on the CD38 ectoenzyme that is on the surface of plasma cells. And each of these lends their own unique flavor to what these two monoclonal antibodies can do in the context of management of patients with multiple myeloma. Now, when we talk about belantamab or belamaf, belamaf is an immunoconjugate that targets BCMA with multiple mechanisms of action as well. Unlike other antibody drug conjugates that lose their ability to fix complement or partner with other effector immune cells, belamaf does have the ability to do ADCC and ADCP, as well as antibody drug conjugate associated direct cell killing, and also induces immunogenic cell death. So each of these really, I think, represent unique and important ways to think about using belamaf, not just in the refractory myeloma setting where it's currently approved, but also as we begin to think about partnering it with other drugs, and we begin to think about moving it earlier and earlier in the treatment paradigm overall. It is clear that antibodies do have a major role now in the management of patients in relapsed and refractory multiple myeloma. And certainly in previous discussions that I've had, I think it is important for us to think about patients in first relapse, trying to maximize the benefit of that response, and that using an anti-CD38 as the backbone to which you either add a proteasome inhibitor or an IMiD represents a major step forward in the management of early relapse multiple myeloma. And as you can see here, the preferred category 1 are either DARA plus bortezomib, DARA plus carfilzomib, or DARA plus len. Again, given that most of our patients are progressing on lenalidomide maintenance, the likelihood of partnering with Lendex is pretty low, but certainly there is now significant data partnering with Pomdex if you want to use an IMiD, or with bortezomib dex or Cardex. And some of those trials we'll talk about coming forward as well. Now, again, I think it really is important to stress the importance of this triplet-based combination, particularly focusing on the use of an antibody as the main backbone of therapy. And this data is a couple years old now, but I think really highlights an important factor, and that is the idea of saving good drugs for later may ultimately rob patients of the ability to get that drug. And the reason why I think that's important, as you can see in the top portion of the slide, is that in the non-transplant patient population, you can see the drop-off between each subsequent line of therapy. And what you'll see is that between first and second line therapy, you lose 56% of patients. Between second and third, you lose another 45%. Between third and fourth, you lose another 42%. So if your idea is to save drugs for later, that later may never come because patients may never get the opportunity to have access to that drug. So let's begin the next section of this, which is the interprofessional guidance on using antibody therapy in early relapse. And I will tell you that I feel very fortunate to be part of a great team that really bands together to talk through how to manage patients, and we really do it in a team fashion. And as some of my colleagues will probably note, I make sure that each new patient meets all of the team members at the initial visit, knowing that it takes all of us to really be able to optimally deliver care for a given patient at a given time. So let's start off with this case, and then I'm going to have my panel colleagues here chime in on some of these questions on the right side of the graph here. So this is a 60-year-old female with revised ISS stage 1 multiple myeloma. She had standard risk myeloma. ECOG performance status was good. Initially received RVD induction followed by transplant, and then received R maintenance. She did progress after about 3 years of therapy and had mild renal insufficiency at that time point. So I'm going to pose it to my colleagues. How would you guys approach this? How would we approach this as a team? And tell me a little bit about antibody-based therapy that you guys might consider, that we would think about using, as well as extended exposure to len and how that informs treatment and counseling on sort of next steps and things to anticipate.
Yeah, I think, Sagar, this is a common patient that we see in our practice, that standard risk patient who's progressing on len maintenance. And an antibody-based triplet is, for us, that next treatment. It makes sense for this patient. One of the things that we're always looking at is, comparing that, is this a biochemical progression versus symptomatic? And clearly this patient has symptoms now with some mild renal insufficiency. So it's something that we want to take into consideration as well. This is a fairly young patient, and that extended exposure to len would have us go a different direction in either an IMiD or a proteasome inhibitor with that antibody.
And Catherine, talk to me a little bit about how renal insufficiency might impact choices of therapy in addition to what the patient's resistant to based on prior therapy.
Yeah, absolutely. I was going to say, I agree with Charisse. This is a very common patient we see. Fortunately, with the mild renal insufficiency, an antibody-based triplet would still be very appropriate for this patient. We do have data from the ICARIA trial that I know you're going to be discussing that it is safe to be given in our renal insufficiency patients. So I think using an anti-CD38 monoclonal antibody at this time would be our next go-to. And I know we're going to talk a little bit about the differences between daratumumab and isatuximab, and there are some differences there to choose from, but I think we would use that as our backbone here. And with the renal insufficiency, using something like pomalidomide would still be appropriate for this patient. We could consider carfilzomib as well. So just kind of taking the patient as a whole and thinking about what side effects and dosing strategies might work well for them. But I think that it would be an appropriate next step to use a CD38 monoclonal antibody.
Okay, so if we talk about giving them an anti-CD38 based salvage regimen, whether it's ISA or DARA, what would be some of the counseling steps that you would both make with a patient? Because as we know, I'm usually in and out of the room pretty quickly, and you guys are there to sort of come in and make sure that the patient has the information and support that they need. So what are the things you guys might talk to them about?
I think that, a lot of times that conversation starts with the provider. We've, been watching this, and whether it's the physician or the advanced practice provider, we would open that door to that next line of therapy. So explaining the reasons why, going over their disease status, why we're making that change, and then briefly discuss the regimen that we're recommending and side effects. The beauty of this team approach that we have is then we can then hand it off to our clinical pharmacist to go in and give it a more in-depth conversation at that point. But I think we feel those early questions, maybe the caregiver or family member that's present as well, and give them that opportunity. If this is a patient that we regularly see, we've been having these conversations. So I'd like to think that we've prepared them, because a lot of times we know it's coming because we've seen those small changes. And so we've already had some of these discussions, but at this point, it would be much more in depth.
Yeah, I agree. And I really like being able to come in after those discussions have been had and be able to just go into kind of the details of the regimen. I think it's helpful to provide calendars and really map out what it's going to look like for the patient. So not just talking about the side effects of the drugs, but what days are they going to have to come to the infusion center? How often does that change? And then also talking about with them any supportive care medications that may need to change because of the new regimen. So, oftentimes they're already on their VTE prophylaxis and their VZV prophylaxis, but just kind of making sure that they're still taking those, reiterate why they still need to take those. So I think I try to approach it by discussing the treatment regimen and then also the supportive care as well.
Yeah, I agree. And when we're thinking about counseling on this new option, and patients ask all the time about the timing and when it's time to make that change. And so that's really important when we're looking at this, trying to differentiate, is this a biochemical relapse versus a symptomatic relapse? So we're looking at the timing of it. Is that protein doubling and tripling, or has it been a slow increase? We go back to our CRAB criteria. Do they have any of those features again? And in the case of our patient, we had that renal insufficiency, but we're again looking for that hypercalcemia or those other risk factors. And this is a time that we would actually restage this patient. So we would have had another bone marrow biopsy, had a complete imaging, whether it's a PET CT or whole body CT or MRI, and look at that disease again. We're also looking at those risk features. So this was a standard risk patient, but now we're looking to see, have they acquired something different, like a 17p deletion that would make them high risk? We also want to look at the performance status of our patient who's in front of us. What other comorbidities do they have? And what are those effects from, in this patient's case, that RVD that they got up front and that ongoing lenalidomide? And then it's a discussion with our patient. This is a 60-year-old patient, a good chance this patient's still working. They're going to have thoughts in that shared decision-making on that next line of therapy as well. So we're looking at frailty in the patient as well, and convenience. Patients, want to come different days of the week to get their treatment. So they might see us in clinic, but go to one of our other infusion centers to get their treatment on another day that's more convenient for them. So all of these things take place in these conversations.
So, when we talk about the use of antibody triplets as a next step, I think it's pretty clear that in this patient, the guidelines and the evidence clearly do support the use in category 1 evidence. And as you can see here, if you want to use DARA plus carfilzomib or DARA plus pomalidomide, you have that data with the CANDOR trial and the Apollo trial. If you want to use isatuximab plus Pomdex or ISA plus Cardex, you have that data from the ICARIA and the IKEMA trial, where clearly the PFS was significantly better with the addition of DARA to either of the backbone approaches, and the same with isatuximab. Isatuximab significantly improved the PFS, MRD negativity, and overall response rates by partnering with either POM or carfilzomib in large phase 3 randomized trials. And some of the data that really speaks to that is this data from the CANDOR trial, which is carfilzomib plus DARA-dex. This was published in Lancet very recently and demonstrates a pretty significant prolongation in progression-free survival for the CAR-DARA-dex versus CAR-dex. And I do think it's important to recognize that in some of these patients that the median PFS for the KD arm was actually not that far off from what we would expect in the Endeavor trial. So it's not that one arm didn't perform as well as one might expect. It's that the addition of DARA to carfilzomib really was a pretty significant improvement in progression-free survival. And this is the Apollo data that looked at sub-Q DARA plus Pomdex, which also substantially improved PFS versus Pomdex. And I think it's important that when you try and compare carfilzomib-based combinations with pomalidomide-based combinations using an anti-CD38 antibody, what you'll see from the phase 3 trials is that it looks like the POM-based combinations are shorter. But remember, that's an artifact of the lines of therapy. Most of these trials were enrolled in Europe, where carfilzomib may be first or second relapse therapy, whereas pomalidomide is second or third relapse therapy. So what you're really seeing is not that one drug or one combination is clearly more effective than the other, but instead what I think you're seeing is an artifact of lines of therapy that may impact the ultimate efficacy of that regimen when compared with POM in the relapsed and refractory myeloma setting. So Catherine, you want to talk to us a little bit in terms of what are the next steps, presuming that DARA is what we're going to move forward with?
Yeah, absolutely. So thinking about daratumumab and starting a DARA-based regimen, whether that's with carfilzomib or with pomalidomide, we talked a little bit about the patient education and counseling. So with the daratumumab, one of the biggest things is going to be the route of administration. Now with our subcutaneous formulation being what we prefer over the IV formulation, and the NCCN guidelines do recommend that it can be interchangeably used. So with the Apollo being sub-Q and CANDOR was studied with IV, we could use sub-Q with both. So educating the patient on what that subcutaneous administration is going to look like and the risk for infusion-related reactions. We will review all of their medications that they're currently on for any drug interactions that may require any dose adjustments. As Charisse mentioned, assessing the patient as a whole for any of their comorbidities, any disease cytogenetic changes, or any lingering toxicities from their prior regimen that may make an impact. Supportive care, like we talked about, and then any insurance appeals that may need to be done can be approached by the team. So typically, if it's an oral-based chemotherapy regimen, I will assist with the appeal there. And if it's the infusional-based appeal or peer-to-peer that needs to be needed, the nurse practitioner or a PA will be handling that in the peer-to-peer. So kind of using the team approach to make sure that the patient is cleared from the insurance perspective and is ready to go. Taking a little bit of a closer look at the sub-Q versus IV formulation, the biggest differences is, of course, is the administration. But another thing to point out here is that the dosing is different, with subcutaneous being a flat-based dosing and IV was traditionally a weight-based dosing. The administration with sub-Q is just a 3 to 5 minute push, whereas IV, we saw the lengthy infusions ranging anywhere from an hour and a half to about 8 hours. So we do need to observe our patients with sub-Q DARA. After cycle 1, day 1 at our institution, we do monitor them for 3.5 hours, which was the median time to an infusion reaction in the phase 3 Columba trial. And then with IV, you can always consider using that split dose if you need to for a time perspective. But Charisse, what are some other considerations that you may have when choosing between sub-Q DARA and IV DARA?
I mean, we've pretty much changed the majority of our patients over to subcutaneous. It's just so well tolerated. And you also see the reaction rate go down significantly. It's a convenience for the patient to get in and out of the infusion center quickly. And most of our clinical trials have allowed us to move over as well to subcutaneous. We have a handful of patients who just prefer the IV. They don't want to rock the boat. But for the most part, it's much more convenient for the patient, and we've gone ahead and changed over.
So can either of you speak to the period of observation? You mentioned the period of observation after cycle 1, day 1. What does that look like when you're in cycle 2, or you're at the end of cycle 1 or cycle 15? Because what I'm certainly hearing from a lot of outside providers is that the package inserts suggest they still have that 3-hour observation indefinitely. I don't think that's really been our practice.
Correct. Yeah. We only are observing after cycle 1, day 1. The package insert doesn't, unless it's been recently changed, but to my knowledge, it doesn't specify an exact amount of time. So I think that will be institution specific. We chose what we chose based off of the median time from that Columba trial, but I think that may vary a little. But what we have found is that, the risk for those reactions is significantly reduced after cycle 1, day 1. So we are not observing past that period. Additionally, for our patients that are on IV daratumumab that we are switching over to sub-Q, we are not monitoring those patients at all either. So it's truly only a fresh start that we've been monitoring.
Okay. So let's talk about a couple of other safety and practical considerations when using anti-CD38 antibodies. Again, we talked a little bit about the hypersensitivity reactions. Myelosuppression does not appear to be significant alone, but when combined with the IMiDs, it does appear that the neutropenia certainly is a little bit more significant than one might expect if you were to give either LEN or DARA or ESA by themselves. So certainly you do see a little bit of an overlap in terms of neutropenia grade 3 and grade 4. Mm-hmm. Fatigue, I think, is something that patients often experience as a consequence of their disease. Sometimes the dexamethasone crash can give you that sense of fatigue as well. One change for us that was almost in a way mimicking what our lymphoma colleagues have done with rituximab, however, was the HBV reactivation issues and screening for hepatitis B core antibody and surface antigens prior to initiation. And I will tell you, I don't think we're perfect in that process of having it all done before their first dose. But I think, Catherine, our approach has been to make sure it's drawn at the time of that first dose, and knowing that we can always come back in with antivirals later on if we need to.
Yeah, I would agree. It's not a contraindication, to not start treatment if those aren't resulted yet. So we will very commonly have those labs drawn on cycle 1, day 1, but they haven't resulted yet back before the patient gets started. But if the results come back positive and we need to start prophylaxis with something like entecavir or tenofovir, we will do that after the fact. So I would agree. It's often done on their first day of treatment. Yeah, and I think just to go a little bit more into detail with some of the hypersensitivity reactions, we mentioned this briefly before, but there is a difference with the DARA formulations as well as with isatuximab. So I'm kind of pooling all of the different data from all the trials together. We see around a 48% reaction rate with the first dose of IV daratumumab. It's significantly lower, as Charisse mentioned, with sub-Q daratumumab at around 11%. And then with first dose of isatuximab, it's around the 40% range. So we do require pre-medications for all three of these monoclonal antibodies. Notably across all three, you'll see your antipyretic with acetaminophen, diphenhydramine, as well as a corticosteroid. We typically are using dexamethasone because that's part of their treatment regimen already, but you can also use methylpred as well. With isatuximab, the package insert does recommend an H2 antagonist as well. And then just clinically, the daratumumab products do have post-infusion recommendations that we used to use. We have really kind of cut those out of our practice, and we are not using those unless patients really experience that steroid crash. We may give them a low dose a couple of days after, but for the most part, in terms of preventing infusion reactions, we've stopped using those post medications and really only use these required pre-medications.
Okay. So let's get back to our patient. What if Michelle had received isatuximab? How would the team's interventions have changed in terms of management? I don't think it would have changed the answer to question 1 or 2. It might have changed the answer to question 3. So let's talk a little bit about what we might have said differently for ISA versus either sub-Q or IV Dara.
Well, I think one of the biggest differences is that it will be an IV infusion, so it won't be a subcutaneous injection. And then the biggest difference to me, I think, is the ongoing every other week dosing. So daratumumab does eventually go to a once monthly dosing schedule, whereas isatuximab remains on the every other week dosing frequency. So having that conversation with the patient, as Charisse mentioned, this patient might very well still be working. Do they have the ability to come to the infusion center twice a month, or would that be very burdensome? Doing monoclonal antibody infusions on the weekends can be challenging at some institutions because they may have less staff. The long infusions and risk for reactions may prevent some of that. So a lot of times this does have to be done on a weekday, which could be limiting. So really the counseling points I think are very similar. The biggest difference to me would be the administration, but Charisse, you may have some other thoughts as well.
No, I mean, that is pretty much it. It's that timing of the infusion and that it stays at that day 1 and 15, day 1 and 8. I'm sorry, day 1 and 15 on that long term. And it's so working out the infusion, working it out with their schedule.
Yeah. No, I think those are subtle but important differences for people who are thinking about using isatuximab going forward. I mean, I think this is the data that really established the benefit of isatuximab with PomDex. This is the ICARIA trial. And again, in a 2 or 3 prior lines of therapy group of patients, you can see a significant improvement in PFS, almost doubling of PFS. The data does look quite similar to the Apollo trial, again, with both of which used POM in the POM label indication, which might explain why some of the progression-free survival is a little bit shorter than what I think many of us are used to seeing. If you then go to the IKEMA trial, which looked at ISA plus Cardex, again, what you see is a substantially improved progression-free survival. And as I mentioned before on the Candor trial, the KD arm actually performed almost identical to what it did in the Endeavor trial, 18 versus 19 months for the control arm, really demonstrating the potency of ISA plus Cardex in that phase 3 setting here. And as I mentioned before, if you begin to look at patients who received, who were in CR, stringent CR, and MRD negativity, almost double, if not higher, rates were associated with the use of ISA Cardex compared to Cardex alone overall. And I think really relevant to the case presentation that we made here is that the benefit for ISA Cardex was seen in patients whether or not they had renal insufficiency. But I think what we're beginning to learn, and in fact, our center has a trial now looking at anti-CD38 antibodies in the context of newly diagnosed myeloma who present with renal failure. that anti-CD38 antibodies are really very good at rapidly reversing renal insufficiency. I think we've always thought about the PIs and dexamethasone as playing in that role. I would now add the anti-CD38s to this as well. And as you can see, the benefit was really quite striking whether patients had normal or abnormal renal dysfunction for the addition of isatuximab in the context of the IKEMA trial. So we now really think about bortezomib, dexamethasone, and anti-CD38 as the three drugs we begin to use very rapidly when patients present with renal dysfunction of any reason in the newly diagnosed or the relapsed myeloma setting.
Yeah, I think we've touched on several of these, but just thinking about some specifics with isatuximab. So the dosing is going to be that weight-based dosing, similar to the IV daratumumab, so 10 milligrams per kilogram. The administration is weekly for the first 4 weeks of cycle 1, and then it goes to that every other week until disease progression. The average infusion time is around 3.5 hours with this product. One thing to point out that I think is important to note is that to date, we do not have any data in patients who previously received daratumumab. So there is some question of if they've already received one anti-CD38, can we use another one? And we currently do not have any data to support that. But there are sub-Q formulations that are being investigated for this product. So I think that that will be something to look out for in the future. And Charisse, if you have other comments for this drug.
I think we've pretty much covered it. We know that AEs reported in the clinical trials, the infusion reactions for isatuximab was about 38%. Our nurses are well versed on handling that in the infusion center, so that first dose can take longer. We see some reactions with upper respiratory tract infections as well as diarrhea, so that's not unusual. We have to keep in mind, again, sending that type and screen prior to initiation of an anti-CD38. Inform the blood bank if the patient is receiving isatuximab. These infusion reactions are very well managed. We have a lot of experience with that, with the pre-medications, as you talked about, Catherine. And we're going to monitor for neutropenia in these combination regimens. It's really more that other component that's probably causing more of the issue if you have it with an IMiD where it could be myelosuppressive. So we're monitoring those blood counts, checking the chemistry on the patient, but monitoring for signs of neutropenia and infection in these patients.
Yeah, and go ahead, Catherine.
Oh, well, I was just going to say, I think one point on the neutropenia component that we have been discussing lately a lot more as a group is the use of G-CSF for these patients, both for a daratumumab or an isatuximab-based regimen. But if they are experiencing neutropenia and we want to keep with that dose intensity of the IMiD or the PI, being able to use once weekly, twice weekly growth factor to help maintain that dose intensity is something that I think we've been utilizing more in our practice.
We have, and even if you need to throw it in the second and third week when you really start to see more of that drop, just so you can get their counts back up by the time they're starting day one of that next cycle.
Yeah, I think the infection prophylaxis is something we've begun to see a lot more frequently with the anti-CD38 antibodies. There are a lot more patients that get URIs or get treated with antibiotics. And so the threshold for giving those, I think, has always been low in myeloma. I think it's even lower now with the anti-CD38 antibodies. But more importantly, the use of IVIG, I think, is something that we're using a fair amount more as well. And we don't routinely give it for a number. I think it's important that because it's not uncommon for myeloma patients to have a low IgG level, but sometimes that IgG can be quite functional and they don't have significant issues. And even if we do use IVIG therapy in patients that have had frequent infections, we do try and give a 6-month run and then a break, because I think the idea of continuous IVIG is just, it's tough for patients to stay on over time. Okay, so let's switch gears now a little bit and talk to a team-based approach to antibody options in a much more challenging patient population where we do have fewer choices in patients with heavily pretreated multiple myeloma. So we know that that we do have new options in the context of refractory myeloma. So let's talk through this case. This is a 76-year-old gentleman with RISS stage 2 myeloma initially, did have underlying coronary disease and somewhat limited mobility. Initial treatment consisted of VRD induction, transplant, R maintenance, and achieved a CR. Relapsed several years later, and then received Pomdex, had progression and then received Darapomdex, achieved a VGPR, and then about a year later developed a new L2 plasmacytoma with a rising M protein, was switched to carfilzomib, cyclophosphamide, and dexamethasone, worked initially but had progression after about 7 months of therapy. So I think this, at least in my mind, is a patient population that we're going to be thinking a little bit about a BCMA-directed therapy. How would the group think about CAR versus ADC and sort of counseling the patient on pros and cons of each of those approaches?
Yeah, for this patient, Sagar, he's a little bit older. He has some underlying other comorbidities. And, we would certainly talk about both options, but the CAR T could be just a little more aggressive for this patient. It might struggle with it a little bit more, coming up with something, looking that he could still receive in the clinic. He's progressing pretty rapidly, really, through, regimens, and it makes sense to switch to a different type of treatment at this point, to something like BCMA therapy. So, thinking more about an ADC makes sense in my mind for this patient.
Yeah, I agree, Charisse. And I think a couple of other things that we could consider for this patient or patients in general when deciding between the two. I think your point about his rapid disease progression is a really big one, because we know that antibody drug conjugates are kind of off the shelf. We can typically get these patients started on their new treatment in about a week. Pending everything comes together, whereas CAR T is going to take several weeks to get the product made. So we may not have time, or we may need to use bridging therapy for that patient. And then also something to consider, I don't know where this patient lives and his caregiver support situation, but with the CAR T cells, they do have to live close to the center, and they cannot drive for 8 weeks after. And of course, we'll talk about a little bit of the driving and eye issues coming up with belamaf. So that's a consideration there too. But I think those are some things that, for a patient perspective and what their life might look like, that we would talk about with the patient.
Yeah, no, I think that's a great discussion in terms of pros and cons if you're going to choose a BCMA-directed therapy on trying to help a patient think through what the optimal responses is. It's very interesting. I find that patients have sort of already done some of that work before they come in, and they've got a preconceived notion about what they want. And then when you actually start going through the data, they realize that it's not such a simple discussion overall, I think, as we struggle with as well. So let's talk a little bit about the DREAM2 data, which led to the FDA approval of belantamab mafodotin, or belamaf, in a heavily pretreated relapsed refractory myeloma patient population. So this was a randomized phase 2 with about 90 plus patients in both arms, one receiving the 2.5 mg per kg dose and the other receiving the 3.4 mg per kg dose, which was the recommended phase 2 dose. And what we noted in that trial was that the 3.4 mg per kg dose was not significantly more effective and did have more grade 3, grade 4 ocular toxicity, which we're going to talk about going on forward. But it's important to recognize these were patients with a median of 6 to 7 prior lines of therapy, very heavily pretreated. Many of them had pre-existing cytopenias, renal dysfunction, and other complications as comorbidities of their treatment before they even came onto the trial. And I think what really struck me when I first saw this data in the interim review was not just the overall response rate, but really was the duration of response. And the reason why I really hit on this in the context of refractory myeloma is that patients often have a lot of comorbidities that they bring to the table with refractory myeloma. So DOR, or duration of response, to me is a composite endpoint bringing together safety and efficacy. And so you have drugs that have 30% response rates in refractory myeloma, but the DOR is very short because patients can't tolerate that treatment. They don't stay on it for very long. And so I think that to me is a real benefit of belamaf, is that the DOR is one of the longer DORs we see of any drug in refractory myeloma, whether it's DARA, carfilzomib, pomalidomide, selinexor, melflufen, or even bortezomib back in the original, 20 years ago when it was approved as well. So I think that that to me is really important. And what you'll see on the right is that the response rate doesn't really change based on prior lines of therapy. And I think that's a lot to do with BCMA being such a new target for the management of patients. Now, as we know, in every drug, once it works in refractory myeloma, we try and bring it a little bit earlier. And this is the DREAM-6 study, which combined belamaf with bortezomib and dexamethasone. And what I think you'll see here again is that the overall response rate jumped to 78%. Many of these patients were refractory to bortezomib, and yet they did respond when you added bortezomib into to belamaf. And that again really speaks to some of the synergy that we saw when you bring these drugs together overall. And more recently, Suzanne Trudell and her group from Canada have presented data on the Algonquin study. And the Algonquin study is a combination of belamaf with pomalidomide and dexamethasone. And if you, again, it's a relatively small study. It was a phase 1, phase 2 run-in. But if you look at these patients, in aggregate, the response rate was in the 80s. When you look at IMiD-PI refractory, it was in the 90s. And when you look at IMiD-PI and DARA refractory, with only 11 patients, the overall response rate was 100%. And what I think this really speaks to is the combinability of belamaf with other standard agents, and the fact that the IMiD antibody combination really is very potent and powerful, which I think is of significant importance when we're thinking about combining these drugs together. So, Sharif, let's talk a little bit about sort of how we play tag team on some of these patients when we talk to them about belamaf as a potential treatment option.
Yeah, so it's whichever one of us is seeing that patient, we open that conversation, and it's, this conversation is a little different because it's a different side effect profile than we've had before. A patient who's relapsed refractory, they're always wanting to know what's that next thing. So, we're going to advise the patient. We're going to go over those side effects with the patient. We're going to bring our clinical pharmacist into it again, but we're going to talk about the possibility of those vision changes for the first time. And, a lot of these patients are older. They might already have some other vision deficits. So those are things that are brought into the conversation. And when you're talking to a patient that you might need a driver to bring you to clinic, the dry eyes, that blurry vision, it's very worrisome to them. Now, the upside of it is when we're starting belantamab, there's no dexamethasone with it. And these patients have had a lot of dexamethasone along the way. So that's something that's positive for them. So for my role, I'm going to talk to them about those side effects, things like advising not to wear their contact lenses. And this will be a collaboration as well with our eye specialist. And Dr. Kim, I know, is going to talk more about this. Using the eye drops that are available, that they want to keep those eye drops in at least 4 times a day. Something that we found on the clinical trials, that dexamethasone eye drops did not help. So I think that's something for the community teams to be aware of as well. Not everybody, will get to see an eye specialist who used this drug and collaborated with us on that. So I think it's important to ensure that these ocular symptoms aren't permanent. What we've seen on the clinical trials, some of these patients get dosed like every 6 weeks and they still respond to therapy. So holding the drug, dose reducing the eye symptoms will improve. So it's not permanent. So I think those are really important things to talk to the patient about when we're bringing on a new drug that has a different type of side effect.
Yeah, and I think, the other thing that I would add in is when you look at the schedule for a patient who's receiving belamaf, it's really 1 dose every 3 weeks. Many of the other drugs we look at in this refractory myeloma patient population, we've got them coming in multiple times a week for count checks or supportive care or hydration or other things along those lines. This really is, outside of the ocular issues, which we're going to talk about in a moment, is a relatively easy drug to give for patients and for them to take as well.
It really is. And, once patients start, they really like that. It's different than everything that we've just, put them through. So it is a much easier regimen to tolerate, and that every 3 weeks is nice for a patient.
All right. So one of the things that came up at ODAC, which was really interesting, was how are hem-onc docs going to partner with eye care professionals and ophthalmologists to really give this drug in a reasonable way. And I thought it was really interesting that one of the medical oncology consultants on ODAC looked at the rest of the panel and said, "We do this all the time with other drugs. Why do you think the hematologists can't figure it out?" John, do you want to mention a little bit about sort of how we partner together in this sort of approach on prevention and monitoring for patients getting belamaf?
Well, first, I'd like to thank you for inviting me to participate in this panel. I think I've learned a lot about multiple myeloma that I have in years since my days in medical school. I think as ophthalmologists, we always seem to be on the outskirts or the edges of internal medicine or the other specialties. And so we're always happy to kind of be able to partner with our other medical specialists to assist them in the care of their patients. And it really leads to a team-based approach to these patients that hopefully is very helpful to your service. I think it's interesting that we've come across this medication that has ocular side effects as really their primary adverse event. And so I think it's great that you guys have been very aware of these events and then be able to incorporate us in the care team. I think it's just to go on, I would say that it's very important to have a really good baseline examination for these patients. These are older patients. I can have a lot of the ocular comorbidities from cataracts to glaucoma to macular degeneration. And then certainly dry eyes is very common in these older patients. And so you really want to get a baseline of what their vision is, what their ocular surface exam is, and really kind of be able to establish what that baseline is so that we can follow any changes that may be related to these medications.
Yeah, and I do think one of the really key parts is, and I feel very fortunate to have partnered with you and others in the group here, that recognition that sometimes there's a sense of urgency for these folks, that I know you guys are usually booked out 6-7 months in terms of your schedules, but sort of getting that early partnership to say, we may not have a lot of lead time to get people started, and we're going to need that flexibility to be able to get folks in and then get them on your schedule going forward, given that they're going to need exams going forward with relative frequency. And so I think establishing that trust and that discussion early on, I think, is really important for this to work for patients ultimately, right?
Oh, correct. And I think, I think our schedules are always busy. I'm sure your schedule is always busy as well. But we can usually kind of fit that one more patient in. They tend to come in, and that's probably a long part of their day to be in our office to go through all the steps and the testing that we do. But fortunately, we're here on campus together, and a lot of other practices may not have this benefit. But since we're on the campus together, we'll usually the patients that when they come in for the day of their treatment, and then we can get an assessment of how they've done since their last treatment, and then kind of be able to forward that on to you on whether the next step in the treatment's okay, or based on the criteria, do we need to make some changes, and we can communicate that to you. Right.
Yeah, no, I think that's really important. So Catherine, you want to talk to us a little bit about the nuts and bolts of getting a patient on to belamaf?
Yeah, absolutely. So this medication does have a REMS program due to the ocular toxicity side effects. I could probably talk about the REMS program for an entire hour on itself, so I'll try to be brief here. But the REMS program involves the oncologist has to enroll, and then the oncologist can assign delegates. So Dr. Loniel is enrolled in the program, and then he has assigned his nurse practitioners like Charisse. as well as myself as the clinical pharmacist, as his authorized delegates, to be able to submit some of the paperwork as well. The patients will enroll. We typically do this when we educate them on their new treatment regimen. So it's kind of all part of that process of educating them on the side effects, the eye drops, the no contacts, and then we'll get them to sign the paperwork to enroll. And then uniquely also, the infusion center has to be enrolled in the REMS program. So I think that's one very important step that needs to be mentioned, especially for some of the institutions that may have multiple infusion sites, making sure that they're all enrolled properly. And our pharmacists in the infusion center at Emory are the ones that will complete that final checklist portion of the REMS program. So once we get all the REMS set up, patients will see the ophthalmologist or the optometrist at baseline, and then they will see them every 3 weeks thereafter to evaluate their eyes for any toxicity and if we can safely proceed. The belantamab does have the antibody component, so there is that risk for infusion reactions. We have standardly pre-medicated all of our patients with acetaminophen and diphenhydramine. The recommendation in the package insert is not that that has to be given initially up front, but what we found in our experience is that patients were having reactions. So we have put that in as our standard of care. And then the counseling portion we've talked about already, and coordinating with our eye care professional partners is very critical as well. So some of just the dosing considerations, we will start out at the 2.5 milligram per kilogram dosing, which was the FDA approved dosing for this treatment. It's a 30-minute infusion, which is really great for our patients who may be more accustomed to some of those more lengthy infusions. So the REMS program, we talked about getting everybody enrolled, and then prior to each exam, we will submit what's called patient status form to clear them for infusion. And patients will be instructed to start their eye drops at that time as well. So I will bring this back to Dr. Kim, but part of my role is that I can help kind of facilitate some of the forms that need to be completed for these patients. So in our practice, as Dr. Kim mentioned, it's super great that they're on campus with us. It makes it so much easier that the patient can come first thing in the morning, or their first part of their day. They can come see the eye care professional and then get their labs done, come see us, and then go to the infusion center. So in a perfect world, that's how we try to do it, where everything can be done on the same day. But the eye exam is good for 14 days. So you do have that period of time if your patient does want to see a eye care professional in the community and then bring that paperwork to you. We've done that for several of our patients that live farther away. But typically what I do when we have a patient that we're starting on belamaf is our nurses will get them set up with their appointment. So we heavily rely on our team to get everything scheduled. So the nurse will get everything scheduled for the patient. And then once that eye care professional is identified, I will send them the forms in our electronic medical record. So if I saw that Dr. Kim was seeing our patient, I would say, hey, Dr. Kim, you're seeing this patient tomorrow for their baseline exam. Here's the form that we will need filled out. And then I will pass it off to Dr. Kim for what kind of happens after that.
I think it's great. I think it's certainly good to get that little heads up that we're expecting a patient for these for treatment evaluations. I think I said before, it's very important to get a good baseline examination. So that includes a slit lamp examination, good evaluation of the ocular surface, a refraction that tests if their vision can be improved with the change in their glasses. And then and certainly a dilated examination, as a baseline to see if there's any other underlying retinal issues. From there, you have to establish that baseline and certainly get their first treatment. The next treatment dose is, say, at least 1 week after the initial dose, and then or 2 weeks before the second dose. The way our setup goes is that the next evaluation is really a lot of times that day of the planned next treatment. And that actually probably works better than doing it too soon after the first treatment, because if there are some initial side effects, and make sure the patient's aware that the vision can be a little bit blurrier early on after that first treatment. But some of it may resolve as you get closer to the planned second dose. And so if we see them really too soon, we're going to say, oh, they may have more of a grade 2, grade 3 type evaluation, and do they need to hold their next treatment? Whereas if you see them closer to the next planned dose, their symptoms actually may improve, and then we can proceed, or let you guys know that it's okay to proceed with the next treatment.
Yeah, I think that's a really important point, because I think sometimes that is lost on the ability not just to develop, but actually resolve. And so that timing, I think, is important.
And sure, I think we definitely like to emphasize what they need to do during this treatment regimen, and that's really to use preservative-free artificial tears. And so it's a little different than the regular big bottles that you can kind of find on the shelves. These are typically going to come with these individual vials, and I think it's very important, since these patients are going to be using these drops very frequently during the day, to emphasize that they should be the preservative-free medications. So we say at least 4 times daily, but they can use them up to 8 times, or even every hour, if it really seems to be helping, their symptoms, helping with their vision. But definitely that it's preservative-free type of medications for the teardrops. I'm sorry for that. Then as they get closer to the next treatment dose, and again, for us, the day of the next planned dose, then we can really evaluate them after they've been using their eye drops, and hopefully assess them, and if their symptoms are resolved or the findings are good, then they can proceed with the next treatment.
Yeah, and I think that one thing we have done for a couple of our patients, to your point of making sure they get the right eye drops, is that there is an eye drop supportive care program through GSK for patients that have difficulty obtaining the correct eye drops. So that's something that we can also enroll them in. And I've enrolled a couple of our patients in to where they'll get eye drops mailed to them. So we have utilized that before. And then the other most common toxicities that we see with these patients is typically thrombocytopenia and anemia, especially in patients if they're starting out kind of with a low reserve to begin with. So we may need to bring them in for platelet transfusions or blood transfusions based off of their blood counts as well.
So John, you want to talk us through a little bit about what you look at when you're seeing what's going on? And in specific, this patient did achieve an early response, but got grade 2 keratopathy on exam after the 4th infusion. The infusion was subsequently held and did drop his best corrected visual acuity by about 2 lines. So you want to talk to us a little bit about what that looks like? And
Sure. A couple things that we'll see in the cornea, the main ocular surface of the eye, the window of the eye, are the punctate type staining changes that you'll see with fluorescein. And so in the photograph here is some examination of the cornea using a cobalt blue light, and that really highlights the staining that you see from the fluorescein. And maybe tough to see in the exact picture, but it's really these little dot-like green dots that you see that indicate that kind of devitalized epithelium, and that may relate to the toxicity related to belamaf. The other things that you'll kind of see is known as these MECs, or these microcyst-like changes in the cornea epithelium, and those a lot of times you'll see initially on the periphery, and they'll kind of work their way in towards the center, with time. And those combined between the kind of punctate changes and the microcysts, that would contribute to changes in their vision, so the blurriness they may feel, grittiness or foreign body sensation they have, and really sometimes a change in their vision that we can see with patients on belamaf.
yeah, and so in this patient, they did develop a grade 2 keratopathy. And so based on that, the dose was ultimately held. Do you want to mention a little bit, because I'm going to show the scale here as well for grade 3 and grade 4, about the pattern with which the MECs begin and then how they regress when you hold the dose?
Sure. We think it I think the pathophysiology of these microcysts is still kind of unknown, but it's probably changes that get incorporated the limbal stem cells. So those are located out in the periphery of the cornea, kind of where the cornea meets the sclera, and those are the cells that go on to produce the corneal epithelium. And so as they kind of move their way through their division and their process and development, they're going to start out in the peripheral cornea. And so as those cells kind of, again, go through their development, you see the changes move progressively centrally as the normal changes in the epithelium occur. And it's really when they become more in the central visual axis is when you start seeing some more of the visual symptoms with that. So the grade 2 type changes, you may see them more in the periphery. Then grade 3 becomes more central. I guess I will say that the grading is typically based on the worst eye. So if you have one eye that's only lost one line of vision or have mild corneal changes, but the other eye, for again, it could be asymmetric effect, it has more grade 2 changes, then we kind of report that to you guys and say, well, do you have to withhold treatment or do you modify treatment? And that, is a little more gray area that kind of let you guys kind of make a decision on, if they've had a really great benefit from this treatment, is it okay still to proceed? And a lot of times the eye findings, even though they're kind of still considered maybe grade 2, are on the more mild side of grade 2. And so again, it's something that we kind of communicate with you guys to say whether it's okay to still treat when it's still quote grade 2 type changes.
Yeah, no, I think that's really important, and for a couple of reasons. Obviously, to know how to best approach the patient, but even more so, you mentioned the MECs typically start at the periphery and work centrally. When you hold a dose, they start to regress more centrally quicker than they do peripherally, and that's why there's a disconnect between time to visual acuity correction, which is relatively short. The average is 21 days, versus time to keratopathy regression, which is closer to 40 or 50 days, because again, that visual issue is much more central, which I think accounts for some of that. And if we look at DREAM2 in terms of overall frequency of adverse events, what I think you'll see is 72% of patients developed keratopathy of any form, but only about 56% actually had symptoms with that, and only 18% had best corrected vision changes of 20/50 or worse. So only 18% actually hit that 20/50 threshold that requires significant dose modification, and only 3 out of the 95 patients actually had to stop because of keratopathy as well. So I think that these numbers put it a little bit more in perspective, and the reversibility piece that we see so frequent, I think, is important as well, because pretty much every patient that develops significant keratopathy does have regression over time. And so no patient has developed permanent, long-lasting visual changes as well. So I think as we sort of wrap up the belamaf management approach, from my perspective, we're excited to have a potential treatment option for patients with heavily pretreated relapsed refractory myeloma. It does require that partnership in a multidisciplinary care team with our eye care professionals and ophthalmologists to really help us gauge the impact that belamaf is having on vision, and then make sure we take that into account when we make decisions on treatments. And then our whole care team really does come around this patient to make these decisions. As Catherine had mentioned previously, we don't typically use significant pre-medications unless patients develop adverse events. And I think we're very fortunate to have a system that really facilitates this kind of high-level partnership amongst all of our specialists here. I don't know if anybody else wants to add any further comments as well.
Yeah, I would agree that it's really to emphasize, with the patient that it's certainly common to develop these eye findings, the eye symptoms, but in pretty much every case that we've been involved with here, they all have resolved. There's just been no permanent loss of best corrected visual acuity, and really even no permanent kind of symptoms and related to kind of the dry eye type findings that we see.
I think that's really important too. And we discuss with our patients and just also reinforce that while you do have that 14 days for that exam, like you said, Dr. Kim, getting it closer to their actual next dose gives us a better idea of what, if we've had improvement, then we can actually treat the patient.
Well, thank you all. I really want to thank my colleagues for just a tremendous discussion on a number of different challenging patient-related topics that I think brought home the importance of this team-based approach in the management of patients with relapsed and refractory multiple myeloma.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/JBG860. This educational activity is supported by educational grants from GlaxoSmithKline and Sanofi Genzyme.